Question 1. A 55-year-old male collapses. You are the first rescuer to reach him. What is the most critical initial action you should take? A. Check for a pulse and begin ventilations. B. Activate the emergency response system and get an AED. C. Begin chest compressions immediately. D. Open the airway and check for breathing. Answer: C. Begin chest compressions immediately. This question tests the foundational principle of the ACLS sequence for an unresponsive adult. The most critical initial action for a collapsed patient without a known cause is to begin high-quality chest compressions immediately, as prompt blood flow to the brain and heart is paramount. The keyword "most critical initial action" guides you to the intervention that has the highest impact on survival. For example, if you see someone collapse, you should prioritize pushing hard and fast on their chest. Always remember that early, uninterrupted chest compressions are the cornerstone of successful resuscitation. Question 2. Which of the following rhythms is treated with immediate unsynchronized defibrillation? A. Symptomatic bradycardia. B. Atrial fibrillation with rapid ventricular response. C. Pulseless ventricular tachycardia. D. Stable ventricular tachycardia. Answer: C. Pulseless ventricular tachycardia. This question assesses knowledge of shockable rhythms in cardiac arrest. Pulseless ventricular tachycardia, private, is a cardiac arrest rhythm where the ventricles are beating rapidly but ineffectively, leading to no pulse, and it requires immediate unsynchronized defibrillation. The keyword unsynchronized defibrillation specifically points to conditions where a patient is in cardiac arrest. For instance, if the AED advises a shock for a patient who is unresponsive and has no pulse, it's delivering an unsynchronized shock. Remember that defibrillation is critical for restoring a normal rhythm in these life-threatening situations. Question 3. What is the primary purpose of epinephrine administration during cardiac arrest? A. To decrease myocardial oxygen demand. B. To increase heart rate and improve contractility. C. To cause peripheral vasoconstriction and improve coronary and cerebral perfusion. D. To convert ventricular fibrillation to a perfusing rhythm. Answer: C. To cause peripheral vasoconstriction and improve coronary and cerebral perfusion. This question focuses on the pharmacological actions of epinephrine in cardiac arrest. The primary purpose of epinephrine during cardiac arrest is its alpha-adrenergic effect, which causes peripheral vasoconstriction, diverting blood flow to the vital organs like the brain and heart. The keyword "primary purpose" directs you to the most crucial effect in this emergency. For example, by squeezing the blood vessels, epinephrine helps ensure that essential organs receive blood during CPR. Always remember that epinephrine optimizes blood flow to key organs during resuscitation efforts, improving the chances of return of spontaneous circulation, ROSC. Question 4. A patient presents with a regular narrow complex tachycardia at a rate of 180 bpm. They are alert and their blood pressure is 120/80 mmHg. What is the initial intervention? A. Immediate synchronized cardioversion. B. Amiodarone 150 mg for over 10 minutes. C. Valsalva maneuver, vagal maneuvers. D. Adenosine 6 mg rapid 4 push. Answer: C. Valsalva maneuver, vagal maneuvers. This question tests the initial management of stable narrow complex tachycardia. For a stable patient with a regular narrow complex tachycardia, the first intervention is typically vagal maneuvers like the Valsalva maneuver, as these can sometimes terminate the arrhythmia by increasing parasympathetic tone. The clues: regular narrow complex tachycardia, alert, and blood pressure is 120/80 mmHg indicate the patient is stable. For example, asking a patient to bear down as if having a bowel movement might slow their heart rate. Remember to always try vagal maneuvers first in stable patients before considering medications or electrical cardioversion. Question 5. What is the recommended chest compression depth for an adult patient during CPR? A. At least 1 inch 2.5 centimeters. B. At least 2 inches 5 centimeters. C. At least 3 inches 7.5 centimeters. D. At least 1.5 inches 4 centimeters. Answer, B. At least 2 inches 5 centimeters. This question assesses a critical component of high-quality CPR. The recommended chest compression depth for an adult during CPR is at least 2 inches 5 centimeters but no more than 2.4 inches 6 centimeters, ensuring adequate blood flow to vital organs. The keyword recommended emphasizes adherence to current AHA guidelines. For instance, imagine pushing on a firm sponge with enough force to noticeably compress it. Always ensure your compressions are deep enough to be effective without being excessively deep. Question 6. During a cardiac arrest resuscitation, effective team communication is critical. Which communication technique involves the team leader explicitly asking for and receiving a verbal confirmation of a task completion? A. Closed-loop communication. B. Call and response communication. C. Direct communication. D. Affirmative communication. Answer, A. Closed-loop communication. This question tests knowledge of effective team dynamics in resuscitation. Closed-loop communication is a vital technique where the team leader gives an order, the team member repeats the order, and then reports back when the task is completed, ensuring clarity and accountability. The phrase explicitly asking for and receiving a verbal confirmation points directly to this technique. For example, the leader might say, administer 1 mg epinephrine, the nurse repeats, 1 mg epinephrine given, and the leader confirms, understood. Always practice closed-loop communication to minimize errors and improve team performance during critical events. Question 7. A patient in cardiac arrest has been intubated. How often should ventilations be delivered? A. 1 breath every 3 to 5 seconds, 10 to 12 breaths/min. B. 1 breath every 6 seconds, 10 breaths/min. C. 2 breaths after every 30 compressions. D. Asynchronous ventilations based on capnography. Answer, B. 1 breath every 6 seconds, 10 breaths/min. This question pertains to ventilation rates in a patient with an advanced airway during cardiac arrest. Once an advanced airway is in place, ventilations should be delivered asynchronously at a rate of 1 breath every 6 seconds, without pausing chest compressions. The clue patient in cardiac arrest has been intubated indicates an advanced airway is present. For example, the person doing compressions should continue without interruption while the person managing the airway delivers a breath every 6 seconds. Remember that continuous chest compressions are paramount, and ventilations should not interrupt them once an advanced airway is secured. Question 8. What is the immediate treatment for a patient experiencing symptomatic bradycardia who is unresponsive to atropine? A. Transcutaneous pacing. B. Immediate synchronized cardioversion. C. Amiodarone infusion. D. Defibrillation. Answer, A. Transcutaneous pacing. This question assesses the management of symptomatic bradycardia. For a patient with symptomatic bradycardia who is unresponsive to or cannot receive atropine, transcutaneous pacing is the immediate next step to increase the heart rate and improve symptoms. The keywords symptomatic bradycardia and unresponsive to atropine are crucial indicators for this intervention. For instance, you would apply pacing pads to the patient's chest and back and gradually increase the current until electrical capture and a mechanical pulse are achieved. Always consider pacing when a patient remains unstable with a slow heart rate despite initial medications. Question 9. Which of the following is considered a non-shockable rhythm in cardiac arrest? A. Ventricular fibrillation, VF. B. Pulseless ventricular tachycardia, private. C. Asystole. D. Polymorphic ventricular tachycardia. Answer: C. Asystole. This question tests the ability to distinguish between shockable and non-shockable rhythms in cardiac arrest. Asystole is a non-shockable rhythm, meaning there is no electrical activity to defibrillate, and therefore, chest compressions and epinephrine are the primary interventions. The keyword non-shockable rhythm points to rhythms like asystole or pulseless electrical activity, PEA. For example, if the cardiac monitor shows a flat line, defibrillation will not be effective. Remember that recognizing non-shockable rhythms is crucial to avoid inappropriate defibrillation and focus on other life-saving measures. Question 10. What is the recommended dose of intravenous, 4, or intraosseous, IO, epinephrine for cardiac arrest? A. 0.1 milligrams. B. 0.5 milligrams. C. 1 milligram. D. 2 milligrams. Answer: C. 1 milligram. This question assesses knowledge of critical pharmacology in cardiac arrest. The recommended dose of intravenous, 4, or intraosseous, IO, epinephrine during cardiac arrest is 1 milligram, administered every 3 to 5 minutes. The keyword recommended dose refers to the standard guideline. For instance, after confirming 4/IO access, you would draw up 1 milliliter of the 1 to 10,000 concentration epinephrine to administer. Always remember that correct dosing of medications is essential for effective resuscitation outcomes. Question 11. What is the most common reversible cause of pulseless electrical activity, PEA? A. Myocardial infarction. B. Stroke. C. Hypovolemia. D. Sepsis. Answer: C. Hypovolemia. This question focuses on identifying reversible causes of cardiac arrest, specifically PEA. Hypovolemia, or severe blood loss/fluid depletion, is the most common and easily reversible cause of PEA, as it leads to an empty heart unable to pump blood effectively despite electrical activity. The keyword reversible cause emphasizes finding and treating underlying issues. For example, if a trauma patient collapses, massive blood loss could be the reason for their PEA. Always consider and aggressively treat the HS and TS to improve outcomes in PEA. Question 12. During post-cardiac arrest care, what is the primary goal for systolic blood pressure? A. Maintain systolic blood pressure less than 90 millimeters of mercury. B. Maintain systolic blood pressure greater than 100 millimeters of mercury. C. Maintain systolic blood pressure between 90 to 100 millimeters of mercury. D. Maintain systolic blood pressure greater than 90 millimeters of mercury. Answer: D. Maintain systolic blood pressure greater than 90 millimeters of mercury. This question addresses a key aspect of post-cardiac arrest care. For patients who achieve return of spontaneous circulation, ROSC, after cardiac arrest, the primary goal is to maintain a systolic blood pressure greater than 90 millimeters of mercury to ensure adequate perfusion to vital organs. The keyword primary goal directs you to the most important blood pressure target. For example, if the patient's blood pressure drops below 90 millimeters of mercury, you would administer 4 fluids or vasopressors to increase it. Remember that maintaining adequate blood pressure is crucial for preventing further brain and organ injury after resuscitation. Question 13. Which action should be taken immediately if ventricular fibrillation, VF, is identified on the monitor? A. Administer intravenous atropine. B. Perform synchronized cardioversion. C. Defibrillate immediately. D. Begin transcutaneous pacing. Answer: C. Defibrillate immediately. This question tests the immediate response to a shockable rhythm in cardiac arrest. When ventricular fibrillation, VF, is identified, it indicates cardiac arrest, and immediate defibrillation is the most critical intervention to terminate the chaotic electrical activity and restore a perfusing rhythm. The keywords ventricular fibrillation, VF, identified and immediately highlight the urgency for defibrillation. For instance, if the monitor shows VF, you should charge and deliver a shock as quickly as possible. Always remember that rapid defibrillation is the most effective treatment for VF. Question 14. What is the recommended dose of adenosine for the initial treatment of stable supraventricular tachycardia, SVT? A. 3 mg rapid 4 push. B. 6 mg rapid 4 push. C. 12 mg rapid 4 push. D. 20 mg rapid 4 push. Answer: B. 6 mg rapid 4 push. This question assesses the initial pharmacological treatment for stable SVT. The recommended initial dose of adenosine for stable supraventricular tachycardia, SVT, is 6 mg given as a rapid intravenous push, followed by a flush, to temporarily block AV nodal conduction and terminate the rhythm. The keyword initial treatment signifies the first drug dose to be administered. For example, you would inject the adenosine quickly into a proximal foreport and immediately follow with a rapid 20 ml saline flush to ensure the drug reaches the heart promptly. Remember that rapid administration and flush are critical for adenosine's effectiveness. Question 15. What is the maximum duration of an interruption in chest compressions during CPR? A. 5 seconds. B. 10 seconds. C. 15 seconds. D. 20 seconds. Answer: B. 10 seconds. This question addresses the importance of continuous chest compressions in high-quality CPR. Interruptions in chest compressions should be minimized and, if unavoidable, should not exceed 10 seconds, as pauses reduce coronary and cerebral perfusion and negatively impact survival. The keyword maximum duration emphasizes the strict limit for interruptions. For example, during rhythm analysis or defibrillation, the pause in compressions should be as brief as possible, ideally less than 10 seconds. Always aim for continuous, uninterrupted compressions to maximize blood flow. Question 16. A patient is suspected of having an acute stroke. What is the critical initial action in the pre-hospital setting? A. Administer alteplase, TPA. B. Obtain a detailed medical history from family. C. Establish last known normal, LKN, time. D. Prepare for immediate intubation. Answer: C. Establish last known normal, LKN, time. This question focuses on the initial assessment for acute stroke patients. Establishing the last known normal, LKN, Time is a critical initial action for stroke patients because it determines the eligibility for time-sensitive thrombolytic therapy like alteplase. The keyword critical initial action highlights the most important step for time-sensitive treatments. For example, asking when was the patient last seen well helps determine the time window for treatment. Always prioritize determining the LKN time in suspected stroke patients to guide subsequent management decisions. Question 17. What is the immediate treatment for a conscious patient experiencing symptomatic bradycardia with hypotension and altered mental status? A. Administer amiodarone. B. Perform synchronized cardioversion. C. Administer atropine. D. Begin chest compressions. Answer: C. Administer atropine. This question addresses the initial pharmacological treatment for symptomatic bradycardia. For a conscious patient with symptomatic bradycardia, indicated by hypotension and altered mental status, the immediate treatment is atropine, which can block vagal effects and increase heart rate. The keywords conscious patient, symptomatic bradycardia, and hypotension and altered mental status indicate an unstable bradycardia. For instance, giving atropine could quickly improve their heart rate and blood pressure, making them more stable. Always prioritize atropine for symptomatic bradycardia unless contraindicated or ineffective, then consider pacing. Question 18. During cardiac arrest, what is the significance of quantitative waveform capnography? A. To confirm proper endotracheal tube placement. B. To monitor the effectiveness of chest compressions. C. To detect return of spontaneous circulation, ROSC. D. All of the above. Answer: D. All of the above. This question highlights the multifaceted utility of quantitative waveform capnography in resuscitation. Quantitative waveform capnography is a vital tool during cardiac arrest as it confirms endotracheal tube placement, monitors the effectiveness of chest compressions by reflecting cardiac output, and can indicate return of spontaneous circulation, ROSC, with a sudden sustained increase in EtCO2. The keyword significance suggests multiple important uses. For example, a sudden rise in the CO2 waveform from a low number to above 40 mm of mercury often signals that the heart has started beating again. Always use capnography to guide and monitor your resuscitation efforts. Question 19. A patient is found unresponsive, pulseless, and apneic. After initiating high-quality CPR, what is the next step according to the ACLS algorithm? A. Establish 4-access. B. Administer epinephrine. C. Attach the defibrillator/monitor. D. Insert an advanced airway. Answer: C. Attach the defibrillator/monitor. This question tests the immediate actions following initial CPR in cardiac arrest. After initiating high-quality CPR for an unresponsive, pulseless, and apneic patient, the next crucial step is to attach the defibrillator/monitor to assess the rhythm and determine if a shock is indicated. The sequence is CPR, then rhythm check. For example, you wouldn't administer drugs or insert an airway until you know if the patient is in a shockable rhythm. Always prioritize attaching the defibrillator early to identify and treat shockable rhythms without significant delay to compressions. Question 20. What is the recommended treatment for a patient in unstable ventricular tachycardia with a pulse? A. Amiodarone infusion. B. Lidocaine bolus. C. Immediate synchronized cardioversion. D. Valsalva maneuver. Answer: C. Immediate synchronized cardioversion. This question focuses on the management of unstable tachycardia. For a patient experiencing unstable ventricular tachycardia with a pulse, indicated by symptoms like hypotension, altered mental status, or chest pain, immediate synchronized cardioversion is the treatment of choice to convert the rhythm safely. The keywords unstable ventricular tachycardia and with a pulse indicate an urgent need for electrical therapy. For example, you would choose synchronized cardioversion to deliver the shock during the R wave, avoiding the vulnerable T wave. Always prioritize synchronized cardioversion for unstable tachyarrhythmias with a pulse. Question 21. What is the initial action for a patient experiencing an acute coronary syndrome, ACS, with ST elevation myocardial infarction, STEMI? A. Administer 4 fluids. B. Obtain a 12-lead ECG. C. Administer amiodarone. D. Prepare for immediate intubation. Answer: B. Obtain a 12-lead ECG. This question tests the initial assessment of an acute coronary syndrome. For a patient suspected of having an acute coronary syndrome, obtaining a 12-lead ECG is the critical initial action as it helps differentiate between STEMI, requiring immediate reperfusion, and non-STEMI, guiding subsequent treatment. The keyword initial action highlights the importance of early diagnosis. For example, the ECG will show characteristic ST segment elevation if it's a STEMI, which dictates an urgent path to the cardiac catheterization lab. Always get that 12-lead ECG quickly when ACS is suspected. Question 22. What is the appropriate initial energy dose for unsynchronized defibrillation of adult ventricular fibrillation, VF, using a biphasic defibrillator? A. 50 to 100 J. B. 120 to 200 J. C. 300 J. D. 360 J. Answer: B. 120 to 200 J. This question assesses the correct energy dose for defibrillation. The appropriate initial energy dose for unsynchronized defibrillation of adult ventricular fibrillation using a biphasic defibrillator is 120 to 200 joules, as recommended by AHA guidelines for effective shock delivery. The keywords initial energy dose and biphasic defibrillator specify the particular setting. For example, if the first shock at 200 J fails, subsequent shocks may be at the same or higher dose, up to the maximum setting. Always ensure you select the correct energy dose for biphasic defibrillation to maximize success. Question 23. A patient is in cardiac arrest due to suspected opioid overdose. In addition to high-quality CPR, what medication should be considered? A. Atropine. B. Adenosine. C. Naloxone. D. Magnesium sulfate. Answer: C. Naloxone. This question addresses specific reversible causes and their treatments in cardiac arrest. For a patient in cardiac arrest suspected to be due to opioid overdose, naloxone should be considered in addition to high-quality CPR, as it can reverse the opioid's respiratory depressive effects and potentially lead to return of spontaneous circulation. The keyword opioid overdose directly points to the use of naloxone. For instance, if a person collapses with pinpoint pupils and slow breathing, an opioid overdose is suspected. Always think of specific antidotes like naloxone when the cause of arrest is known or suspected. Question 24. What is the most reliable method to confirm and monitor the correct placement of an endotracheal tube, ET, during resuscitation? A. Auscultation of breath sounds. B. Chest rise. C. Quantitative waveform capnography. D. Esophageal detector device. Answer: C. Quantitative waveform capnography. This question focuses on advanced airway management during resuscitation. Quantitative waveform capnography is the most reliable method for confirming and continuously monitoring correct endotracheal tube (ET) placement, as it provides a real-time display of exhaled carbon dioxide. While other methods like auscultation and chest rise are initial checks, capnography provides continuous confirmation. For example, if the CO2 waveform suddenly disappears, it likely means the tube has been dislodged. Always use quantitative waveform capnography for definitive and ongoing ET tube confirmation. Question 25. Which of the following is an indication for immediate transcutaneous pacing in a patient with bradycardia? A. Heart rate of 45 bpm with dizziness. B. Heart rate of 55 bpm with no symptoms. C. Heart rate of 60 bpm with mild fatigue. D. Heart rate of 40 bpm with a history of hypertension. Answer: A. Heart rate of 45 bpm with dizziness. This question tests the indications for transcutaneous pacing. Immediate transcutaneous pacing is indicated for symptomatic bradycardia, which includes symptoms like dizziness or altered mental status in the context of a slow heart rate. The keyword immediate suggests an unstable condition, and dizziness clearly indicates symptomatic bradycardia. For example, if a patient is very dizzy or nearly fainting due to a slow heart rate, pacing is needed right away. Remember to always treat the patient's symptoms, not just the heart rate, when considering pacing. Question 26. What is the initial energy dose for synchronized cardioversion of unstable monomorphic ventricular tachycardia? A. 50 to 100 J. B. 120 to 200 J. C. 200 J. D. 360 J. Answer: C. 200 J. This question assesses the energy dose for synchronized cardioversion of specific tachyarrhythmias. For unstable monomorphic ventricular tachycardia, the initial energy dose for synchronized cardioversion is typically 100 joules, monophasic or biphasic, but AHA guidelines permit starting at 100-200 J biphasic, with 200 J being a common initial choice on many devices. The keywords unstable monomorphic ventricular tachycardia and synchronized cardioversion guide you to this specific scenario. For example, if the first shock doesn't convert the rhythm, subsequent shocks are typically escalated. Always ensure you select synchronized mode to deliver the shock safely. Question 27. What is the recommended post-cardiac arrest intervention aimed at reducing brain injury? A. Aggressive hyperventilation. B. Maintaining hyperthermia. C. Targeted temperature management, TTM. D. Immediate surgical intervention. Answer: C. Targeted temperature management, TTM. This question focuses on a critical aspect of post-cardiac arrest care. Targeted temperature management, TTM, which involves cooling the patient to a specific temperature range, is a recommended post-cardiac arrest intervention aimed at improving neurological outcomes and reducing brain injury. The phrase reducing brain injury is a direct clue to TTM. For example, inducing mild hypothermia helps protect brain cells from damage after the heart restarts. Always consider TTM for comatose patients after resuscitation from cardiac arrest. Question 28. Which of the following is a common sign of effective ventilation with a bag mask device? A. Gastric inflation. B. Minimal chest rise. C. Visible chest rise. D. Abdominal distension. Answer: C. Visible chest rise. This question tests the assessment of effective ventilation. A common and crucial sign of effective ventilation with a bag mask device is visible chest rise, indicating that air is entering the lungs and not just the stomach. The keyword effective ventilation points to signs that indicate proper air delivery. For example, when you squeeze the bag, you should clearly see the patient's chest expand. Always ensure you are delivering just enough volume to cause visible chest rise to avoid overinflation. Question 29. A patient is experiencing sudden onset dyspnea, chest pain, and hypotension. The ECG shows sinus tachycardia and S1Q3T3 pattern. What is the most likely cause? A. Acute myocardial infarction. B. Aortic dissection. C. Pulmonary embolism. D. Tension pneumothorax. Answer: C. Pulmonary embolism. This question assesses the recognition of a specific cardiovascular emergency. The combination of sudden onset dyspnea, chest pain, hypotension, and the characteristic S1Q3T3 pattern on ECG strongly suggests a pulmonary embolism, PE, especially a massive one. The combination of symptoms and the ECG findings are key clues. For instance, a large blood clot traveling to the lungs causes these symptoms due to blocked blood flow. Always consider pulmonary embolism in patients with acute respiratory distress, chest pain, and signs of right heart strain on ECG. Question 30. When should carotid artery pulse checks be performed during ACLS? A. For 5 to 10 seconds to confirm pulselessness. B. Continuously during chest compressions. C. Only after every 5 cycles of CPR. D. Only if there is no other sign of life. Answer: A. For 5 to 10 seconds to confirm pulselessness. This question addresses a critical step in the assessment of cardiac arrest. Carotid artery pulse checks should be performed for no more than 5 to 10 seconds to confirm pulselessness before initiating chest compressions, or during rhythm checks to determine if there is a pulse after a shock or medication. The keywords 5 to 10 seconds specify the time limit to minimize interruptions. For example, if you feel no pulse within 10 seconds, you must immediately resume or start compressions. Always limit pulse checks to this brief window to minimize hands-off time during resuscitation. Question 31. What is the maximum recommended dose of atropine for symptomatic bradycardia? A. 1 mg. B. 2 mg. C. 3 mg. D. 6 mg. Answer: C. 3 mg. This question assesses the maximum dosage for atropine in symptomatic bradycardia. The maximum recommended dose of atropine for symptomatic bradycardia is 3 mg, which is typically administered as 0.5 mg for every 3 to 5 minutes, as doses higher than 3 mg generally do not provide further clinical benefit. The keyword maximum recommended dose guides you to the upper limit of safe administration. For example, if a patient has received 3 mg of atropine and remains symptomatic, other interventions like pacing should be considered. Always be aware of maximum drug dosages to avoid adverse effects. Question 32. Which of the following is a key component of high-quality CPR? A. Compressing at a depth of 1 inch. B. Interrupting compressions frequently to check pulse. C. Allowing full chest recoil after each compression. D. Delivering ventilations at a rate of 20 breaths per minute. Answer: C. Allowing full chest recoil after each compression. This question tests understanding of essential elements of high-quality CPR. Allowing full chest recoil after each compression is a key component of high-quality CPR because it allows the heart to refill completely with blood, ensuring adequate cardiac output with the next compression. The keyword "key component" highlights a vital aspect. For example, leaning on the chest between compressions prevents the heart from fully refilling, reducing blood flow. Always ensure full chest recoil to maximize the effectiveness of each compression. Question 33. What is the primary drug for treating recurrent or refractory ventricular fibrillation/pulseless ventricular tachycardia, VF/private, after defibrillation and epinephrine? A. Lidocaine. B. Adenosine. C. Amiodarone. D. Procainamide. Answer: C. Amiodarone. This question addresses the antiarrhythmic drug of choice in cardiac arrest. Amiodarone is the primary antiarrhythmic drug used for recurrent or refractory ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, after initial defibrillation and epinephrine administration, helping to stabilize the cardiac rhythm. The keywords recurrent or refractory and VF/private direct you to this specific scenario. For example, if a patient keeps going back into VF despite shocks, amiodarone is the next drug you'd consider. Always remember amiodarone as the go-to antiarrhythmic in persistent shockable rhythms. Question 34. What is the recommended approach to managing pulseless electrical activity, PEA? A. Immediate synchronized cardioversion and epinephrine. B. Continuous chest compressions, epinephrine, and search for reversible causes. C. Atropine administration and immediate pacing. D. Defibrillation and amiodarone. Answer: B. Continuous chest compressions, epinephrine, and search for reversible causes. This question assesses the management strategy for PEA. The recommended approach to managing pulseless electrical activity, PEA, involves continuous high-quality chest compressions, administration of epinephrine, and an aggressive search for and treatment of reversible causes, HS and TS. The keyword recommended approach points to the standard algorithm for PEA. For example, if you suspect hypovolemia, you would administer fluids while continuing CPR. Always remember that identifying and treating the underlying cause is crucial for PEA. Question 35. A patient has return of spontaneous circulation, ROSC, after cardiac arrest. Which initial post-cardiac arrest intervention is most important to optimize oxygenation and ventilation? A. Administer corticosteroids. B. Secure the airway and ensure adequate ventilation. C. Immediately perform a head CT scan. D. Initiate targeted temperature management. Answer: B. Secure the airway and ensure adequate ventilation. This question focuses on the immediate post-ROSC care. After return of spontaneous circulation, ROSC, securing the airway and ensuring adequate oxygenation and ventilation are paramount to prevent further hypoxic injury to the brain and other organs. The phrase "optimize oxygenation and ventilation" guides you directly to airway management. For example, this might involve confirming ET tube placement and adjusting ventilation settings to achieve appropriate oxygen saturation and EtCO2 levels. Always prioritize ABCs immediately after ROSC to support vital organ function. Question 36. What is the initial intervention for a patient presenting with an acute ischemic stroke within the thrombolytic window? A. Administration of aspirin. B. Mechanical thrombectomy. C. Intravenous fibrinolytic therapy, e.g., alteplase. D. Blood pressure control only. Answer C. Intravenous fibrinolytic therapy, e.g., alteplase. This question addresses the acute treatment of ischemic stroke. For a patient presenting with acute ischemic stroke within the thrombolytic window, typically 4.5 hours from last known normal, intravenous fibrinolytic therapy with alteplase is the initial intervention to dissolve the clot and restore blood flow to the brain. The keywords acute ischemic stroke and within the thrombolytic window are critical. For example, if a patient arrives within 3 hours of symptom onset, they are likely a candidate for this medication, assuming no contraindications. Always consider time-sensitive fibrinolytic therapy for eligible ischemic stroke patients. Question 37. Which of the following is considered an unstable finding in a patient with tachycardia? A. Dizziness. B. Mild chest discomfort. C. Shortness of breath. D. Acute altered mental status. Answer D. Acute altered mental status. This question tests the recognition of instability in tachycardia. Acute altered mental status is a key unstable finding in a patient with tachycardia, indicating poor perfusion to the brain and necessitating immediate intervention like synchronized cardioversion. The keyword unstable finding implies signs of organ hypoperfusion. For instance, if a patient with a fast heart rate suddenly becomes confused or unresponsive, they are considered unstable. Always look for signs of shock, acute heart failure, or altered mental status to determine if a tachycardic patient is unstable. Question 38. What is the purpose of administering magnesium sulfate in polymorphic ventricular tachycardia, torsades de pointes? A. To suppress ectopic beats. B. To correct underlying electrolyte imbalance and stabilize the cardiac membrane. C. To slow the heart rate. D. To increase myocardial contractility. Answer B. To correct underlying electrolyte imbalance and stabilize the cardiac membrane. This question focuses on the specific use of magnesium sulfate in a particular arrhythmia. Magnesium sulfate is administered in polymorphic ventricular tachycardia, specifically torsades de pointes, because it helps to correct the underlying prolonged QT interval, often caused by electrolyte imbalances like hypomagnesemia, and stabilizes the cardiac membrane. The phrase torsades de pointes is the direct clue. For example, if a patient's ECG shows a twisting pattern of QRS complexes, magnesium is the immediate drug to consider. Always remember magnesium as the specific treatment for torsades de pointes. Question 39. During CPR, what is the recommended rate of chest compressions? A. 60 to 80 compressions per minute. B. 80 to 100 compressions per minute. C. 100 to 120 compressions per minute. D. 120 to 140 compressions per minute. Answer C. 100 to 120 compressions per minute. This question tests a fundamental aspect of high-quality CPR. The recommended rate of chest compressions during CPR is 100 to 120 compressions per minute, which ensures adequate blood flow to vital organs during resuscitation efforts. The keyword recommended rate refers to the established guideline. For example, maintaining this rate ensures that enough blood is circulated while minimizing fatigue for the rescuer. Always aim for a consistent rhythm within this range to maximize CPR effectiveness. Question 40. What is the immediate intervention for attention pneumothorax causing cardiac arrest? A. Chest tube insertion. B. Needle decompression. C. Positive pressure ventilation. D. Pericardiocentesis. Answer B. Needle decompression. This question addresses the immediate treatment of a reversible cause of cardiac arrest. For a tension pneumothorax causing cardiac arrest, identified as a T in the HS and TS, immediate needle decompression is the life-saving intervention to relieve the trapped air and pressure on the heart and lungs. The phrase tension pneumothorax causing cardiac arrest specifies the urgency. For instance, inserting a needle into the second intercostal space midclavicular line allows the trapped air to escape. Always treat a tension pneumothorax emergently, as it's a rapidly fatal condition if not addressed. Question 41. When managing a patient with acute coronary syndrome, which medication is typically given first, if not contraindicated? A. Morphine. B. Oxygen. C. Aspirin. D. Nitroglycerin. Answer: C. Aspirin. This question focuses on initial pharmacological management in acute coronary syndrome. For a patient presenting with acute coronary syndrome, aspirin is typically the first medication administered, if not contraindicated, due to its antiplatelet effects that reduce clot formation in the coronary arteries. The keyword first emphasizes the priority. For example, giving 162 to 325 milligrams of chewable aspirin helps prevent the clot from getting larger. Always prioritize aspirin for suspected ACS patients to limit myocardial damage. Question 42. A patient experiences sudden cardiac arrest in a hospital setting. The most important initial action of the first responder is to A. Begin chest compressions. B. Call for a defibrillator. C. Check for a pulse. D. Open the airway. Answer: A. Begin chest compressions. This question reinforces the immediate actions in cardiac arrest, even in a hospital setting. Regardless of the environment, the most important initial action for a witnessed or unwitnessed cardiac arrest is to immediately begin high-quality chest compressions. The phrase "most important initial action" emphasizes the primary life-saving maneuver. For example, if you see someone collapse, you should start pushing on their chest right away. Always prioritize early and effective chest compressions for a patient in cardiac arrest. Question 43. What is the initial action if a patient with an advanced airway experiences a sudden decrease in end-tidal CO2, EtCO2? A. Increase ventilation rate. B. Check for airway obstruction or dislodgement of the ET tube. C. Administer bronchodilators. D. Increase oxygen concentration. Answer: B. Check for airway obstruction or dislodgement of the ET tube. This question addresses troubleshooting advanced airway management. A sudden decrease in end-tidal CO2, EtCO2, for a patient with an advanced airway often indicates a problem with the airway itself, such as obstruction, dislodgement, or disconnection. The keywords "sudden decrease in EtCO2" in the context of an advanced airway are the crucial clues. For example, the endotracheal tube might have slipped into the esophagus or become kinked, so you must assess its position and patency immediately. Always troubleshoot the airway first when EtCO2 suddenly drops. Question 44. What is the recommended dose of lidocaine for refractory ventricular fibrillation/pulseless ventricular tachycardia if amiodarone is not available or contraindicated? A. 0.5 to 0.75 mg/kg for bolus. B. 1 to 1.5 mg/kg for bolus. C. 2 to 4 mg/kg for bolus. D. 50 mg for bolus. Answer: B. 1 to 1.5 mg/kg for bolus. This question assesses alternative antiarrhythmic drug choices in cardiac arrest. If amiodarone is not available or contraindicated for refractory ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, lidocaine is an alternative antiarrhythmic, with an initial recommended dose of 1 to 1.5 mg per kilogram for bolus. The scenario if amiodarone is not available or contraindicated guides you to the alternative. For example, if your hospital doesn't stock amiodarone, lidocaine would be your next choice for a patient in persistent VF. Always know the appropriate alternative drugs and their dosages for critical situations. Question 45. What is the most common cause of sudden cardiac arrest in adults? A. Stroke. B. Respiratory failure. C. Acute myocardial infarction, heart attack. D. Drug overdose. Answer: C. Acute myocardial infarction, heart attack. This question tests basic knowledge of cardiac arrest epidemiology. The most common cause of sudden cardiac arrest in adults is acute myocardial infarction, heart attack, which often leads to lethal arrhythmias like ventricular fibrillation. The phrase "most common cause" refers to the leading etiology. For example, a severe blockage in a coronary artery can cause the heart's electrical system to malfunction. Always remember that underlying heart disease, particularly heart attack, is the primary driver of adult sudden cardiac arrest. Question 46. What is the first priority when assessing a patient who is unresponsive? A. Check for a medical alert bracelet. B. Open the airway and look, listen, and feel. C. Shake and shout to determine responsiveness. D. Check for breathing and pulse simultaneously. Answer: C. Shake and shout to determine responsiveness. This question focuses on the initial assessment of an unresponsive patient. The very first priority when encountering a potentially unresponsive patient is to shake and shout to determine if they are truly unresponsive or just sleeping, ensuring you do not immediately proceed to interventions like CPR unless necessary. The phrase "first priority" directs you to the very initial step. For example, tapping the patient's shoulder and loudly asking, "Are you all right?" is the initial assessment. Always confirm unresponsiveness before moving to the ABCs of resuscitation. Question 47. What is the appropriate management for an adult patient in asystole? A. Immediate synchronized cardioversion. B. Defibrillation, then epinephrine. C. High-quality CPR, epinephrine, and search for reversible causes. D. Atropine administration and immediate pacing. Answer: C. High-quality CPR, epinephrine, and search for reversible causes. This question assesses the management of a non-shockable rhythm. For an adult patient in asystole, the appropriate management involves continuous high-quality chest compressions, immediate administration of epinephrine, and an aggressive search for and treatment of reversible causes, HS and TS, as defibrillation is not effective. The keyword asystole indicates a non-shockable rhythm. For instance, if the monitor shows a flat line, you should focus on excellent CPR and finding out why their heart stopped. Always remember that asystole is treated with CPR and epinephrine, not shocks. Question 48. What is the recommended oxygen saturation target for a patient receiving post-cardiac arrest care? A. 90 to 94%. B. 94 to 98%. C. 98 to 100%. D. Greater than 92%. Answer: D. Greater than 92%. This question addresses a key target in post-cardiac arrest care. For patients receiving post-cardiac arrest care, the recommended oxygen saturation target is greater than 92% to avoid both hypoxia and hyperoxia, as both can be detrimental to neurological outcomes. The keyword recommended refers to the current AHA guideline. For example, if a patient's SpO2 is 99%, you might consider decreasing supplemental oxygen to avoid hyperoxia, but ensure it doesn't drop below 92%. Always aim for a SpO2 of 92% or greater to optimize oxygen delivery while preventing harm from too much oxygen. Question 49. Which of the following is a common contraindication for the use of nitroglycerin in acute coronary syndrome? A. Systolic blood pressure greater than 100 mm of mercury. B. Recent use of phosphodiesterase inhibitors, e.g., sildenafil. C. Mild headache. D. Normal ECG. Answer: B. Recent use of phosphodiesterase inhibitors, e.g., sildenafil. This question addresses specific contraindications for a common cardiac medication. Recent use of phosphodiesterase inhibitors, like sildenafil or tadalafil, within 24 to 48 hours is a major contraindication for nitroglycerin due to the risk of severe, life-threatening hypotension. The keyword contraindication implies a reason not to give the drug. For example, if a male patient with chest pain admits to taking an erectile dysfunction drug recently, you must absolutely avoid nitroglycerin. Always ask about phosphodiesterase inhibitor use before administering nitroglycerin. Question 50. In the pulseless arrest algorithm, after 2 minutes of CPR and no return of spontaneous circulation, ROSC, what is the next step if the rhythm is still ventricular fibrillation, VF? A. Administer atropine. B. Administer an additional epinephrine dose. C. Defibrillate, second shock. D. Perform advanced airway insertion. Answer: C. Defibrillate, second shock. This question tests the progression of the pulseless arrest algorithm. After 2 minutes of high-quality CPR and the first shock, if the rhythm remains ventricular fibrillation, VF, the next step is to deliver a second defibrillation shock, followed immediately by another 2 minutes of CPR. The phrases pulseless arrest algorithm, 2 minutes of CPR, and rhythm is still ventricular fibrillation indicate the need for repeated defibrillation. For example, you would charge the defibrillator and deliver the second shock, then quickly resume compressions. Always follow the rhythm check shock CPR sequence in the pulseless arrest algorithm.